All right, so tonight's objectives, we're going to discuss the structures, processes, and functions of the brain, describe the current neurobiological research and theories that are the basis for current psychopharmacological treatment of mental disorders, discuss the nurse's role in educating clients and families about current neurobiological theories and medication management, identify pertinent teaching for clients and families about brain imaging techniques, discuss the categories of drugs used to treat mental illness and their mechanism of action, potential side effects, and special nursing considerations, identify, client responses that indicate treatment effectiveness, and then discuss common barriers to maintaining the medication regimen. All right, so this is just a review. This is our central nervous system. So we know in our brain, we have our cerebellum, our brain stem, our limbic system. We have our spinal cord, and then we have all the associated nerves that control the different voluntary acts that we have. So our brain actually has two hemispheres. All of the lobes and structures are found in both halves, except for the pineal body or the pineal gland, some people call it, which is going to be located between the two hemispheres. So 4 lobes in each hemisphere. We have the frontal, the parietal, the temporal, and the occipital. The frontal lobe, that helps with our thought, our body movement, all of our memories, our emotions, and our moral behavior. Our parietal lobe is responsible for our taste, our touch, our special orientation. Temporal lobe is smell, hearing, memory, and emotional expression. And then our occipital lobe is language, visual interpretation. So the cerebellum is located just below the cerebrum. It is our brains, it's the center for coordination of all of our movements, our posture adjustments when we go to sit up and reposition ourselves. It also has a role in reception. So it kind of integrates all the information from all the other body areas to help coordinate that movement. And there is some research that has shown that inhibited transmission of dopamine, which is a neurotransmitter, is associated with the lack of smooth, coordinated muscle that we would see in dementia and then also in Parkinson's. So this is our brain stem. So we have the midbrain. So this is where the reticular activating system is, so which controls our motor activity, our sleep, our consciousness, and things that we're aware of. And it also is home to the extrapyramidal system. We have our pons, which is the primary motor pathway, the medulla oblongata. This is the vital center, so our cardiac and our respiratory function. Also going to find the nuclei for all those cranial nerves. And then we have the locus ceruleus. This is the norepinephrine producing neuron. So these are going to be seen with anything related to stress, anxiety, and then when we engage in impulsive behavior. The limbic system is just above the brain. It is home to the thalamus, the hypothalamus, the hippocampus, and the oblongata. The thalamus is activity, sensation, and emotion. The hypothalamus is responsible for our temperature regulation, appetite control, our endocrine function, sexual drive, and impulsive behavior. Our hippocampus is our emotional arousal and our memory. And then our amygdala is the emotional arousal and memory. All right, so we learned a little bit about neurotransmitters back in pharmacology. So neurotransmitters are chemical substances that our body uses to facilitate neurotransmission. They're manufactured in the neuron. They aid in the transmission of information throughout the entire body. They can either be excitatory or inhibitory. So if they are excitatory, that means that they excite. If they are inhibitory, that means that they stop an action. They inhibit from happening. Neurotransmitters are made so that they fit into a specific receptor cell. These receptor cells are embedded in the membranes of the dendrite, and they're kind of like a lock and key. They both fit inside of each other in a perfect match to stimulate the neurotransmitters. They're important in the correct proportions so that our body is able to relay messages from one area of our body to the other. They do play a role in psychiatric illness. Differences in amounts available in the brains of people with certain mental illnesses. So when they study different mental illnesses and they do studies on certain people, they have noticed that certain people that have certain mental illnesses or mental disabilities have varying degrees of different neurotransmitters, usually less than people who don't have any type of mental illness. And they also play a role in psychotropic medications with regards to their actions and the side effects. So this is a good picture of dopamine and the dopamine receptor and how they all fit like a lock and key. So this is a deficient neurotransmitter here. So you can see on the end of this pink one here, you have all these little pieces coming off. 1, 2, 3, 4, 5, 6, 7, 8 little pieces coming off. Well, when it tries to fit in this little piece right here, it's never going to match up because there's only 3 things there. Where over here, there's 6, and then there's only 3 on this one. This is going to be excess. So there's too many. So not enough little prongs over here and too many over here. So this is a good example of how we have these issues with neurotransmitters. So we said that they could be inhibitory or excitatory. So our excitatory neurotransmitters are going to be dopamine, norepinephrine, epinephrine, and glutamate. So dopamine is located primarily in our brainstem, and it plays a role with all of our complex movements, our motivation to do things, our cognition, and our regulation of our emotional response. Norepinephrine is also located primarily in the brainstem, and it plays a role in changes in our attention, our ability to learn and retain information, what we can remember, what we will be able to recall after we've learned, our sleep-wake cycle. It has a big part in our mood regulation. Excessive is implicated in several anxiety disorders and deficits, which may contribute to memory loss, social withdrawal, and depression. And then epinephrine, that's our fight or flight response in the peripheral nervous system. And then glutamate is major neurotoxic effects at high levels, not so much when they're lower. So our inhibitory neurotransmitters are going to be serotonin and GABA. So serotonin is involved in the control of how we regulate our food intake, also has a role in our sleep-wake cycle, our temperature regulation, how we control our pain, our sexual behavior, and how well we regulate our emotions. It also has a huge role in anxiety, mood disturbances, and schizophrenia. Some antidepressants will block serotonin reuptake, which allows it to stay longer in the synapse, which will absolutely bring your mood up, improve your mood, because your body has more serotonin. Serotonin plays an important role in, we already said that, anxiety, mood disorders, and schizophrenia. It has been found to contribute to delusions, patients having hallucinations, and then withdrawal behavior that we see in patients that have schizophrenia. And then GABA, it is a major inhibitory neurotransmitter in the brain. It modulates other neurotransmitter systems rather than directly stimulating them. It just kind of, they have like a modulatory effect on them. They don't directly stimulate them, they work through other processes. So these are going to be seen, we see them in drugs that increase, that can increase the GABA in our body. So benzodiazepines do these, and then we can use them to treat anxiety and then also induce sleep. So these are the structures of the neurotransmitters. This is actually from your book, so you guys can find this in your book. Then we also have neurotransmitters that can be excitatory or inhibitory. So acetylcholine, it is found in the brain, the spinal cord, and peripheral nervous system. Our skeletal muscle, it signals muscles to become alert. It is synthesized from dietary choline that you can get from red meat and certain vegetables. Eating red meat and vegetables will help activate that sleep cycle and our muscles. And then clients with Alzheimer's disease and myasthenia gravis are known to have decreased acetylcholine secreting neurons. So acetylcholine definitely plays a role in the development of those two diseases. And then we have histamine, which is a neuromodulator. So they don't really know a lot about why it has the effect that it has. It's something that they're still investigating. It is involved in peripheral allergic responses. It also plays a role in the control of our gastric secretions, some cardiac stimulation, and then alertness. And some psychotropic drugs block histamine, which results in weight gain, sedation, and hypotension, which is why those are unwanted side effects. And those are contributing reasons why some people don't stick to their medication regimens. So it used to be years ago that the brain could only be studied when patients died through an autopsy or if they had to go into the brain for some reason to do some type of a surgery. We've made a lot of advancements over the years with modern technology. So we can use a CT, an MRI, a PET scan, and then an SPECT. So a CT is just a X-ray beam that takes cross-sectional images. So it actually slices the image that it's looking at and it goes layer by layer. So it's pretty detailed. An MRI, which is more detailed than the CT, is an energy field created with a huge magnet, and it also uses radio waves and then converts those radio waves into a visual image or a scan. It will produce more tissue detail and contrast than a CT. We have a PET scan, which provides better resolution with sharper and clearer pictures, but the downside is it takes about 2 to 3 hours. We don't usually use it for diagnosis when it comes to mental health. For the medical field, we do, but for mental health, it's really only seen in times where they're researching something. And then we have the SPECT. So this is another test that takes a little bit of time. About 1 to 2 hours. Again, we don't use it for medical diagnosis. It's mainly for research. So some of the limitations that you would find for having these tests performed is the use of radioactive substances. Do they have any allergies to the contrast, things like that? Can the client tolerate it? And then the expense of the equipment. So are they paying out of pocket? Maybe they can't afford it. Does their insurance cover it? And then changes that are non-detectable with current techniques. So disorders such as schizophrenia are at the molecular and chemical levels. So if you perform either a CT or an MRI or a PET scan, you won't be able to see any changes. Some diseases you can take these tests and see like a progression, a decline. You won't really see that with these tests in these certain conditions. So There is a lot of research that says that genetics and hereditary play a role in a person developing a mental illness. It's not solely genetic, but it does play a role. It can be genetic. Identical twins. There's a couple studies now where they are looking at identical twins. They've been following them for several years. Everything about them is identical, so they're watching them as they get older to see if they wind up having and comparing them to see if they, if either one of them has any mental issues. If the other one starts to get it, they're trying to bring that genetic component into. There's also studies out there regarding adoption. So a lot of researchers say that even if you have, say you have a mom who used drugs when they were pregnant with the child, and then they gave the child up at birth, and they're raised by a completely different family who never had any drug issues in their family, never did drugs, had a great upbringing, they can still end up with these genetic components. So they are saying that these biological traits are passed on, and regardless of how they are raised, they can still deal with these issues. And then different family studies they look at, so they want to know if more traits are active in certain family members. So, it could be the mother, the father, the sisters, the brothers. So these are all the focus of all these research things that we're seeing. We're trying to nail down all those causes because we want to know, more about mental illness so that we can help, the people who are suffering from it. So it's always ongoing research. So psychoimmunology, so this is when a person has a compromised immune system that could possibly contribute to depression. So there's a big link between patients who have multiple sclerosis, lupus. There's a couple other immunocompromised diseases that are directly related to depression. So they think that patients that have these genetic mutations also have the same genetic mutations that will cause depression and anxiety. And then they also believe that sometimes if a patient is subjected to a certain type of infection, that can actually impact the development of the brain. So if the mom has a virus that could be passed on to the baby when she's pregnant, then they see a higher risk of these children with certain diseases, mental diseases. So what is the nurse's role in education and research for mental illness? Media reports information about new research and studies all the time. It can be very confusing for our patients. Some of the information that we have or that they get can be very contraindicatory. There is some of the information is contraindicated. It can be confusing, and it can also be difficult for families to understand, families, patients. We as healthcare providers are always a good source of information, or at least we are expected to be a good source of information. So we need to know where to get good scholarly articles from. We just don't want to take information that we tell our patients from, yahoo.com. We always want to make sure they're peer reviewed. They come from .gov, .org. Those are good sources of information. We always want to make sure that we keep our clients and our family members well informed. We want to be able to explain to them how to distinguish between what facts are and what are just hypotheses. And then we want to always be able to explain how new research can, in fact, affect our client's treatment or prognosis, because sometimes our patients will be privy to different researches before we even know about them. So if your patients come to you and they say, hey, what about this? Can we try this? Advocate for them, tell them, I haven't heard about that. We can talk to the doctor. Always encourage their involvement. So psychopharmacology, with dealing with mental illness, medication management is going to be crucial for these group of patients. It is going to heavily influence the outcome of treatment, how successful they are, it's also going to dictate if they're able to tolerate the medication and if they're going to continue taking it. That's the big thing that we see in mental illness. We either see they start taking medicine, they don't like the side effects, they stop. They start taking the medication, they don't have too many side effects, or they get used to them, but then they feel good again, and then they don't think they need the medication. They don't realize that, hey, I feel good because I'm taking the medication, and then they stop. And it can be this vicious cycle. And then sometimes the issue is that we have to go through many medications before we find the right one. So there's always certain medications that are considered the gold standards for certain mental illnesses, but it doesn't mean that what works for me would work for you. And sometimes we have to take these medicines for at least 2 to 4 weeks before we see a difference. So after a patient takes a certain medication for a month, then we might have to change it and try another one. And when you're dealing with patients that have anxiety or any kind of psychosis or depression, that can be a very long time for them because they want to feel better. So there's a lot of issues that come along with psychopharmacology. So as nurses, we need to understand how they work. We need to understand what those expected side effects are, any contraindications, and interactions. We need to be able to, when we educate our patients about their medication, we want them to know ahead of time what the side effects are. And then we want to be able to tell them, Mrs. Jones, we're going to start you on this medication for your anxiety. I want you to understand that these are a couple of the side effects you might see. You might be nauseated the first couple of weeks, you might get a headache, but after 2 to 3 weeks, these symptoms are going to resolve because we want them to be successful with their medication. We don't want them to be like, oh, I don't like this side effect, and then think that it's never going to resolve, and then they stop taking the medicine. So we really need to know how they work, what the side effects are so that we can really educate our patients. And then we also need to know the nursing interventions that are required to help them manage these medication regimens. What time of the day should we take them? When do they need to follow up with the doctor? You know, if they're going to stop taking it, how should they taper it down, or how should they taper it up if they're starting off with a small dose? So we need to know about the efficacy of medication. So this is going to refer to the maximal therapeutic effect that a drug can achieve. So we also want to know about potency. This is going to describe the amount of drug that's needed to achieve the maximum effect. We know about half-life from last semester, so this is the time it takes for half of the drug to be removed from the bloodstream. We need to know about off-label use. We also talked about this last semester. So this is when one medication is developed for treatment of one disease, but then we find out after it's been used in a variety of people that it also treats this. It wasn't intended to treat this, but it also works for this problem too. And then our black box warning, these are the serious or life-threatening side effects. So when medications are chosen for patients, it is going to be based on their target symptom. It is evaluated by its ability to be able to diminish that side effect or the symptom, or to eliminate the symptoms completely. So we're talking about anxiety, we're talking about delusions, hallucinations, sometimes if patients they have manic behavior. So we're going to treat those symptoms, and then the medication that the doctor chooses is going to work. They're only going to choose a medication that's just going to work on those symptoms. They are going to make sure that they order an adequate dosage for a sufficient time before they are effective. So we know with tricyclic antidepressants, they can require 4 to 6 weeks before the client experiences that optimal therapeutic effect. So that is going to be something that we're going to want to explain to the patient because we don't want them to say, I stopped taking it. I took it for 3 weeks and I didn't feel better. Well, they haven't even taken it for the maximum amount of time for it to even be sufficient right now. So a lot of education goes into these medication. We always give them the lowest dose to be effective. We don't always start off with the highest dose or a mid dose. We start at the lowest and then they work their way up. Older adults require lower dosage than younger adults because of the therapeutic effects. So it might also take longer for drugs to achieve its full therapeutic effect in the older adult. And then we see a lot more toxic side effects because of the liver function and then the decreased kidney function. When patients are stopping medication, we taper it rather than having them just all of a sudden stop taking it, because they can have rebound side effects. Their symptoms can come back even worse, and they can also go through withdrawal. And then follow-up care is essential. So we never just prescribe a medication to a patient and then send them on their way. Usually, if it's done the correct way, the primary care physician should refer the patient to a therapist that can help them. There are some primary care physicians that will treat mild things like anxiety and depression, but they still require a follow-up. So the patient will get a prescription. They'll have to come back in 3 to 4 weeks. They'll evaluate how the patient is doing and then decide, do we need to change the dose? Maybe we need to go down a little bit, maybe we need to go up a little bit. So follow-up care is essential, and also to manage those side effects. And then we want it to always be the most simplest regimen if possible, because we want to encourage everything that's going to increase compliance, because compliance is so important. So the first type of medication we're going to talk about is antipsychotic drugs. These used to be called neuroleptics. Some of you may have heard that before. Now they're commonly just referred to as antipsychotics. So antipsychotics were designed to treat the symptoms of psychosis, such as delusions and hallucinations. We see delusions and hallucinations in schizophrenia, schizoaffective disorder, and then the manic phase of bipolar disorder. Antipsychotic agents work by blocking receptors of the neurotransmitter dopamine. Dopamine receptors, they are classified into different subcategories. So the subcategories are D1, D2, D3, D4, and D5. D2, D3, and D4 have been associated with mental illnesses. So these first generation antipsychotics that we're going to talk about are potent antagonist blockers of D2, D3, and D4. So the last thing that I just told you about, the D1, D2, D3, I'm not going to quiz you on those. You won't see that on your exam, but I just wanted you to understand how these medications are working and where we think mental illness starts in the brain. So these conventional, or what we call first generation antipsychotic agents, this is going to be your chlorpromazine, your florfenazine, thiorazidine, haloperidol, or we call it Halidol, or loxapine. These first generation conventional antipsychotics do produce many extra pyramidal side effects. I want you guys to remember that. It's very important. These medications produce extra pyramidal side effects. We're going to talk about those side effects a couple slides down. But this first generation, they are well known for causing all those side effects. Our second generation antipsychotics are also called atypical. These will increase mortality rates in elderly clients with dementia-related psychosis. So you have to be very, very careful which patients you use these second generation medications in. This is going to be your clozapine, your risperidone, and your olanzapine. And then we have third generation. So these actually help stabilize dopamine in the brain. It allows for control of symptoms without some of the effects that we see with the other antipsychotic medications. We can use these for schizophrenia, manic episodes, and also as an adjunct medication in both bipolar disorder and depression. So this is going to be your omeprazole or your Abilify, your caraprazine, your brexpiprazole, or your Rexulti. So with these medications, when you guys go to clinical, you will always have access to both of these medications. It's almost always on the MAR. You have the generic and then you have the formulary. I choose whichever one I know I can say. That's the one I pronounce. I don't pronounce both, and I always choose the one that will be pronounced the easiest, because some of these medicines, it's hard to pronounce them. So always choose the one that you know you can pronounce. And then if they're like, I don't know that pill, well, then you can give the other name, because they don't always know it by both name. So the most common side effects that we see with these medications is going to be sedation, weight gain, headache, anxiety, and nausea. You can look on page 23 of your book, your VitaBac book. It'll talk all about these common side effects. And then those, remember we said those first generation antipsychotic drugs have a greater incidence of those extrapyramidal side effects, EPSs, than the second generation. And there's also, when we talk about, there's another medicine that's an antipsychotic that we can use. It's called Ziprasidone or Geodon. This is one of the antipsychotics that rarely causes any EPSs. So this is a medication that a lot of doctors try and use because they don't see a lot of those side effects. All right, so how do antipsychotic drugs work? So they block dopamine, acetylcholine, histamine, and norepinephrine receptors in the brain and the periphery. They promote the inhibition of psychotic symptoms, which is believed to be a result of D2 blockade in the brain. Dopamine receptors, we said, are classified into different subcategories, D1 through D5, and then it is been identified through research that D2, D3, and D4 have been associated with mental illness. We use them for acute and chronic psychotic disorders, schizophrenia spectrum disorders, bipolar, primarily the manic phase, agitation, and then Tourette disorder. Interactions, so you would want to be careful if you were taking them concurrently with other anticholinergic medications, because it can increase the effects of the medication. You could see addictive CNS depressant effects with concurrent use of alcohol, opioids, and antihistamines. So you want to educate your patients that when they're taking these medications, they don't want to drink alcohol, they don't want to take opioids or antihistamines. And then by activating dopamine receptors, levodopa counteracts the effects of the antipsychotic agents in some, with some patients taking that medication. All right, so we said on the last slide that these medications, these first generation medications, cause a lot of these extrapyramidal syndrome side effects. They cause serious neurological issues. So blockade of those D2 receptors are responsible for the development of these EPSs. First generation has a greater incidence than the second generation. So you can see acute dystonia. So acute dystonia is a severe spasm of the tongue, the neck, the face, and the back. You can have torticollis, which is where you get a twisted head and a neck, which is what you see in the picture there. Opistonias, which is a tightness in the entire body where the head and the neck become arched. Oculogyric crisis, this is where your eyes will roll back and they'll roll back in your head and they'll get into like a lock position. If these things start to happen, any of those three right there, you would want to stay with your client. You want to monitor their airway, because we're talking about that tightness in the body. We're talking about issues with the head and the neck being arched. So we always want to make sure that their airway isn't compromised. So if you're dealing with any patients that have this, stay with the patient, monitor their airway until the spasm subsides. Usually takes about 5 to 15 minutes, depending. Treatment, we would give anti-Parkinsonian agents, so benzotrophine or Benadryl. You could give it IM or IV. You can also see pseudo-Parkinsonism. So this is where your patients will seem like they have Parkinson's, but they don't. It's just caused from this drug. So your patients are going to present with a stooped posture. They're going to be rigid. They're going to have a mask-like face. So you're not going to see any type of expression on their face at all. They might be drooling. They might be shaking. They're going to have tremors. They'll kind of have like that shuffling gait, and then they'll do this pin rolling in their thumb and finger. So it's going to look like they have Parkinson's, but they don't. It's just from these antipsychotics. What would we want to do? So we would want to give anti-Parkinsonian agents, so that benzotropine, or we want to change the patient's medication that would have a lower incidence of developing the EPSs. We would want to implement interventions to reduce the risk of them falling. They could also get akathisia. So this is where the patient will be restless. They will have an inability to sit or stand. They're going to have anxiety, and they're just going to have continual pacing. They're going to be walking all over the place. They're not going to be able to help themselves and just sit down and relax. And they're also going to be agitated. So we would manage this with anti-Parkinsonian agents, just any anti-cholinergic. We could use beta blockers, or we could also use lorazepam or diazepam, which is Ativan. And then we would want to monitor the patient for an increased risk of suicide. So you guys need to understand that what these extrapyramidal syndrome, what it is, what the side effects are, how you would recognize it, and how you would treat it, okay? So this is kind of just like a little mnemonic, the clinical features of Parkinsonism. So pill rolling tremors, akathisia, which is the inability to sit, rigidity, kinesia, which is a defect in movement, unstable posture, so they're going to be stooped over, no arm swinging in rhythm with legs, excessive flow of saliva, siluria, oculogric crisis, that is a mouthful. That's where you have the deviation and the fixation of the eyeballs. They roll back in the head, nervous depression, involuntary tremors, sevoria, which is, and you have an issue with your sebaceous glands, and then they're going to have those masked facial expressions. So you can also have, as a side effect, neuroleptic malignant syndrome. So that other slide that we just talked about, this one here, these are all the extrapyramidal syndrome side effects that you would see. When we move to this slide, these are just other side effects, but they are not EPS. All right, I don't want you to get that confused. So neuroleptic malignant syndrome, or NMS, this can be fatal. It's an idiosyncratic reaction to an antipsychotic. Your patients will present with rigidity. They will have a high fever, autonomic instability, so that you could see unstable blood pressure. You could fluctuate, or it could just be, at the opposite end of each spectrum, diaphoresis, pallor, delirium, and then you would see some of their enzymes would be elevated. If this is going to occur, it usually occurs within the first 2 weeks of therapy. How do they treat it? They discontinue all of the antipsychotic medications, and then they institute supportive medical care to help treat the blood pressure, the dehydration, and the hyperthermia from the fever. Patients can also develop tardive dyskinesia, which is irreversible involuntary movements. So this is where the tongue, the facial and the neck muscles, the upper and lower extremities, and the truncal musculature all get, they kind of get stiff, or sometimes they can't control them very well. The patient may be rocking back and forth. They do this thing with their tongue. It's called a tongue thrusting. And it sometimes it's hard to identify in patients when it first starts. It just seems like they're kind of like smacking their tongue on their lip a little bit, kind of like might just seem like they're licking their lips. As it progresses, after years of being on this therapy, the tongue will actually hang out of the mouth, even at rest. And it looks like it has swollen a little bit, it gets big. So the tongue will thrust, it's gonna protrude, you're gonna have lip smacking, the patients blink constantly, and then they will be grimacing. So the thing to monitor here is that you wanna make sure you are evaluating this patient every 3 months. Once this starts, it doesn't stop. We can't really reverse it, even if we discontinue the medication. So that's why it's so important to really monitor these patients. A lot of these medications will cause anticholinergic effects, dry mouth, constipation, urinary hesitancy, or retention. Some of these antipsychotics cause orthostatic hypotension. Usually this will resolve itself within 1 to 2 weeks of therapy. You can have severe dysrhythmias. So depending on which medication you're going to prescribe, if it's one that has a high likelihood of developing dysrhythmias, before the doctor starts the patient on it, the doctor would order a baseline ECG or EKG and a potassium level. So these medications will affect the potassium in your body, which we know what potassium does, right? It affects our heart. So that's why they're at risk for developing these dysrhythmias. So get that baseline ECG, check the potassium levels, and then monitor them periodically. And then we can also see liver impairment. So if we know this is a medication that could really damage the liver, then we would want to get a baseline liver function before they start treatment and then monitor it periodically. And there's more in your book. Table 2.4 talks about the extrapyramidal side effects. So this is the pseudo-Parkinsonism, that stooped posture, that shuffling gait, the rigidity, the tremors are going to be at rest, that pill rolling. Next to that is that acute dystonia. That's what you would see, the tardive dyskinesia down at the bottom right, and the akathisia, that restlessness, trouble standing still, pacing on the floor. And I got this from your book too, so you can refer to your book. So other side effects that we see, we could see increased prolactin levels, breast enlargement and tenderness in men and women, decreased libido. There can be erectile and orgasmic dysfunction, menstrual irregularities with some patients, an increased risk for breast cancer with some medications, weight gain. So these are, we're going to see a lot of the second generation medications are known for weight gain, especially that ziprazidone, prolonged QT intervals with the thiazone, the droperidol, and the mesarid, I hate saying these medications, mesoridazine. You're going to see that in the EKG. And if you did see that, that would probably be a good reason for discontinuing that medication and starting another. And then some of these medications can also cause dangerously low white blood cell counts, mainly the clozapine. So if your patient is taking clozapine, what lab do you think that you would want to monitor for your patient if they're at risk for infections?
White blood cell count?
White blood cell.
Very good. Yeah, white blood cell count. Monitor for infection. So if they say, if they come in and they're taking that medication, they're like, I had a fever this morning, or I had a sore throat. Well, you know that they're at risk for developing that. So, all right. So nursing administration and teaching. So we want to make sure that we are teaching the patient that is really important to adhere to the regimen. Take that medication as prescribed on a regular schedule. Teach them what to expect with regard to those unpleasant side effects, and then teach them how to manage them. Advise the client that some therapeutic effects can be noticeable within a few days, but for significant improvement, it can take 2 to 4 weeks and possibly several months for full effect. So when they come to you and say, I've been taking this for 3 weeks now, I'm not taking it anymore, I have a dry mouth, it's hard for me to pee, and I'm not feeling any better. A lot of education. This is what you're going to expect. It'll subside in a couple of weeks. Keep taking this medication. We haven't seen the maximum effect of this medication yet. If you educate them about that before they start taking it and they know what to expect, you're going to see a lot more compliancy. Educate them about reporting issues with their medications or unpleasant side effects to the physician instead of stopping the medication. Tell them to call into the office and talk to the doctor first. When a client misses a dose, so if they miss the dose, they can take it within 4 hours of the usual time. That's a good rule of thumb. You can advise clients with antipsychotic medications that they can cause, that they rarely cause physical or psychological dependence. So a lot of patients don't want to take certain medications because they're afraid they're going to get, addicted to it. Well, these medications don't have a high probability of dependence. Encourage clients who have difficulty remembering to take their medicine. They can use a chart to log it, even an app on your phone. We have apps on our phones that they can download. They can use a chart to record it, or they can also get a pill box and set it up for the week. Begin administration with twice daily doses, but switch to daily doses at bedtime to decrease daytime drowsiness and promote sleep. So instead of giving, you'll see sometimes if they give that one whole dose at first in the morning, you'll see more side effects. So sometimes they'll say, take half of this pill in the morning, half at night. They do that for 2 or 3 weeks. Then once that little period goes by where there might not have those side effects, then they'll say, okay, you can switch it to daily. And then when they do that, we can say, go ahead and take it at bedtime, because then you're not going to be so sleepy during the day. If it is a drug that causes drowsiness, it's going to help you sleep. And some of those unpleasant side effects you won't experience because you'll be sleeping. So how can we teach them to manage those unpleasant side effects? So for those anticholinergics, we know that they cause patients to be really thirsty and have a dry mouth. We can tell them to have sugar-free candies, drink lots of liquids throughout the day. If they're constipated, some of these medicines do cause constipations. Well, we can do exercise. How will exercise help with constipation?
Gravity, apparently.
It'll move everything around.
Yeah, gravity and motility. It keeps things moving. Yep. So exercising, increase your water intake, increase foods that are high in fiber. If we put more fiber into our stools, remember it bulks our stool up, it makes it weigh more, it stimulates peristalsis, and then they won't be constipated. And then stool softeners, not laxatives, okay? Not laxatives, stool softeners. If they were extremely constipated, then you could say, okay, take a laxative. But for testing purposes, we're only talking about stool softeners. That's important. You guys need to circle that, write it down, make a star. You're going to see that on your exam. When I tell you guys that's important, I should see you all look down at your books and mark it, because that's stuff that's going to be on your exam, okay? Sunscreen, because some of these medications cause photosensitivity. Some drugs cause you to be sedated or be extremely drowsy. So safety measures, you shouldn't be operating heavy equipment. Maybe you shouldn't, if you drive for a living, you shouldn't take that medication while you're working. Just be careful. And then you are going to monitor your CBC and ANC with clozapine, because you're going to be looking for the development of an infection. All right, antidepressants. We use them to treat major depressive illnesses, anxiety disorders, the depressed phase that we see in bipolar disorder, and then psychotic depression. So antidepressants work by interacting with norepinephrine and serotonin. We know that both of these are responsible for regulating our mood, our arousal, attention, our sensory, and our appetite. Clients who have major depression can require hospitalization with the implementation of close observation and suicide precautions until that antidepressant medication reaches their peak effect. I see this all the time. We bring patients in. If they don't have a bed on the psych unit at our hospital, then we have to hold them on these med-surg floors, and we keep them all the time, an indefinite amount of time, especially if we have to make medication changes. We want to make sure that the medication is working. So that is very true. We do that all the time. So there are 4 groups of antidepressants. You have your tricyclic and your related cycle antidepressants. These are your TCAs. We have our selective serotonin reuptake inhibitors, our SSRIs. And then we have our MAO inhibitors, so our MAOIs. Then we also have other typical antidepressants. So venlafaxine, bupropion, duloxetine, trazodone, and Nephetizone. So this is a nice little guide. You can read over this. This talks about the different groups of antidepressants and their commonly seen side effects, and then what medications would cause them. So this is a good chart. So they work by blocking the reuptake of norepinephrine and serotonin in the synaptic space. Therefore, it's going to intensify the effects of these neurotransmitters because they're not going to be able to reuptake it. They're going to keep, there's just going to be more there. So depressive disorders, we also use this in patients that have neuropathic pain, some patients that have fibromyalgia. We can use it for anxiety disorders. Trazodone is a common one we use all the time for insomnia, bipolar disorder, that akathisia, which is that motor restlessness, nausea, and then we also can treat certain issues with sexual dysfunction. All right, so the SSRIs, so they are used to treat anxiety, agitation, akathisia, nausea, insomnia, and sexual dysfunction. You want to advise the clients to, no, I said that wrong. Those are the side effects. I'm sorry. SSRI, those are the side effects you can see from the medication. Advise the clients to take these medications in the morning to minimize sleep disturbances. Advise them to take these medications with food because sometimes it can cause nausea. It can also cause a lack of appetite. And then we can also see weight gain with these SSRIs. Weight gain is a lot of things that I see in my NP clinicals, why people come back after that first month and they're like, I'm not taking this anymore. I gained 10 pounds. All I want to do is eat. Especially for women, this is a big issue. So it's good to talk about that so that they know ahead of time, because if they know ahead of time it could be an issue and it's a medicine that really works, then maybe they'll engage in more physical activity, or they'll monitor what they're eating to help, counteract the weight gain. And then TCAs, so you're going to see anticholinergic effects with these medications. So dry mouth, constipation, urinary hesitancy or retention. Patients complain about dry nasal passages, sometimes nosebleeds because they get so dry, and then their near vision gets blurry. Side effects are common reasons that clients discontinue drug therapy. You can also see orthostatic hypotension, sedation, weight gain, tachycardia. So you're going to monitor for these cardiac dysrhythmias, which could be an indication of toxicity. Administer at bedtime due to sedation and the risk of that orthostatic hypotension. You can also cause sexual dysfunction, and then there is a big potential for suicide by overdose if they take a lot of these. MAOIs, these can cause daytime sedation, insomnia, weight gain, dry mouth, orthostatic hypotension, sexual dysfunction. You could also develop what's called a hypertensive crisis. This is going to happen when you eat a food that contains Tyramine. So if you're on an MOI and you eat a food that has Tyramine, your patient could develop a hypertensive crisis. It occurs when, as a result of intensive vasoconstriction in your vessels, and then a stimulation of the heart. And the combination of the two is going to cause dysrhythmias. So you have to educate your client about what a thiamine diet would look like. And you have to find out if they're actually going to be able to stick to it. So you want to tell them what kind of foods they would have to stay away from. And then you would want to really make sure that they're on board with taking this medication. It can cause headache, nausea and vomiting, increased heart rate, increased blood pressure, diaphoresis, and in some patients, a change in level of consciousness. If you were to see this in the clinical setting, you would provide continuous cardiac monitoring. So they're going to be on a telemetry monitor, and then respiratory support as needed. And you could also administer phentolamine, which is a rapid-acting alpha-adrenergic blocker that would help counteract some of these cardiac symptoms that you are seeing. So foods that contain Tyramine are mature or aged cheeses, certain dishes made with cheese, such as lasagna or pizza. All cheese is typically considered aged except for cottage cheese, cream cheese, ricotta cheese, and then those processed cheese slices in the plastic containers. Wrapped in plastic, I mean. So we have aged meats, so pepperoni, salami, mortadella, summer sausage, beef logs, I don't know what a beef log is, meat extracts, and similar products. You want to make sure that the meat and chicken that they're eating are fresh and that they have been properly refrigerated before they eat them. Italian broad beans, so fava, bean curd, which is tofu. So a lot of vegetarians eat tofu. Banana peel, overripe fruit, and avocado. And then all tap beers and microbrewery beer. So drink no more than 2 cans or 2 bottles of beer, including non-alcoholic beer, or 4 ounces of wine per day. Also sauerkraut, soy sauce, soybean condiments, or Marmite, which is concentrated yeast. And then yogurt, sour cream, peanuts, brewer's yeast, and monosodium glutamate, MSG. There is a lot of MSG in Chinese food sometimes. So those are the things that you would want to educate the patients about. So you do need to know what foods contain Tyramine. You're going to see it on your exam. All right, so the other atypical antidepressants that we are going to talk about, we have Nephetizone, which is going to cause sedation, headaches, dry mouth, nausea, and it can also, in some rare circumstances, cause life-threatening liver damage. We have Trazodone, which is going to cause sedation and headache. So we see Trazodone ordered a lot for patients that have trouble sleeping. We have mirtazapine, which is going to cause sedation. And then you have venlafaxine and desvenlafaxine, which is going to cause a loss of appetite, nausea, agitation, and insomnia. Bupropion causes seizures, loss of appetite, nausea, agitation, and insomnia. Venlafaxine can also cause dizziness, sweating, or sedation. And then Trazodone can also cause priapism, which is a sustained and painful erection that does require immediate treatment, and then you would absolutely have to discontinue the drug. And it can also result in impotence. So if you do have a male patient that's taking this and he says, no, I don't want to stop taking it for the obvious reasons, well, you would have to educate them and say, there are, life-changing results that could come if you keep taking this medication. So they need a lot of education. And then, of course, you would want to advise the client to avoid abrupt cessation of the medication, especially without talking to a provider first. So some patients can develop something called Serotonin Syndrome. This happens when you combine a MAOI and an SSRI together. So if they take two of these medications together, usually it takes about 2 to 72 hours after the start of treatment before they start seeing these symptoms. And it can be lethal, so it can result in death. Patients will present with mental confusion, difficulty concentrating. They might have hallucinations. They may be complaining of abdominal pain. They might have diarrhea. They might have diaphoresis, agitated, anxiety, fever, sweating, tachycardia, hypotension. They may be very rigid. They might have hyperreflexia. They might be incoordinated. And they might present with tremors. And then in extreme reactions, you're going to see coma and possibly death. So you would want to advise the client to observe for manifestations. If there are any, obviously instruct the client to withhold the medication and notify the provider. So this would be the only time that you would tell them to withhold the medication. And these two medications, this isn't the first, the doctor, if the patient came in and said, I've been having anxiety for a couple of years, blah, 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 blah. The doctor wouldn't say, oh, I'm going to give you these two. You would see these two as a combination, kind of like as a last ditch effort to try and help the patient with their mental illness. They've probably already exhausted a long list of medications and nothing else is working. So now they're going to try these medications. So some client teaching that we want to do, we want to instruct the client to take antidepressant medication on a prescribed and a daily basis because we need to establish therapeutic plasma levels. We're not going to see a change in their symptoms or their outlook or the way they feel within a day or two. We need to reach a therapeutic level. You want to assist with the medication regimen compliance by talking to that patient, educating them that that therapeutic effect may not be experienced for 1 to 3 weeks. Full therapeutic results can take 2 to 3 months. So this is why education is so important. And this can be a really long time, 2 to 3 months for someone who's depressed. But education is really key. Instruct the client to continue therapy after improvements in manifestations. Sudden discontinuation of the medication can result in relapse or major withdrawal effects. And some, I even see this with my husband. He doesn't take medicine for mental illness, but he went through a period when he was unhealthy and he took blood pressure medication. And then he would monitor he was very good about monitoring his medication. And after about 6 months in, he was like, I don't need this medication anymore. And I'm like, why? The doctor said you don't need it. He was like, no, my medication's great. I'm like, duh, because you're taking your blood pressure medicine every day. But you see this all the time in the clinical setting. People will say, I don't need to take it. I feel great. Well, you feel great because you're taking your medication. So please don't stop taking it. But this is something, you see patients that go through this for years. It takes them a long time sometimes to really be compliant with their medication. So then we want to talk to them about the time of dosage. So SSRIs, we want to take these first thing in the morning. TCAs, because of their side effects, better to take it at night. If they miss a dose and they're taking an SSRI, they can take that missed dose up to 8 hours after the first one. So if it's been 8 hours since the time they missed it, or more than 8 hours, then they skip it completely altogether and they take their next dose at the next scheduled time. With TCAs, if they forget it, they can take it within 3 hours of the missed dose. And then remember those dietary restrictions if they're taking an MAIO. Use cautiously with patients who have diabetes, and then make sure you provide clients with a list of those foods containing tyramine to reduce the risk of that hypertensive crisis. So then we have mood stabilizing drugs. We use these to treat bipolar disorder. It stabilizes the client's mood, prevents or minimizes those highs and lows that characterize what we call bipolar illness. And we can also use it to treat acute episodes of mania. Lithium is the most established mood stabilizer that we use. It's kind of like the gold standard. It's been around for a long time. It's a very trusted medication. It works very well. Other anticonvulsant drugs are effective. So we have carbamazepine, which is Tegretol, valproic acid, which is Depakote or Depakine, gabapentin, for neuron, as also called Neurontin, topiramate, which is Topamax, oxycarbazamine is Tripatel, and lamotrigine is Lamictal. So these are anticonvulsants. A lot of these medications do a lot of different things. You're going to start to see this when you get in the clinical setting. So gabapentin, we can use it for mood stabilizing drugs. We can also use it for neuropathy. A lot of people that have diabetes mellitus take this because of that neuropathy they have. It helps with the numbness and tingling. We can give Topamax for migraine headaches. So you will see these medications used interchangeably in the clinical setting. Lamotrigine can cause serious rashes that actually require hospitalizations, including Stevens-Johnson syndrome, and rarely they could get a life-threatening toxic epidermal necrolysis. Toxicity is closely related to serum lithium levels. We can see toxicity with patients that take lithium even at a therapeutic dose. I want you guys to know this. This is why it's bolded. You must monitor your patient's lithium levels. If your patient is taking lithium, you must monitor them. Even at just a therapeutic dose, we can see toxicity. The time of the last dose must be very accurate so that the plasma levels can be checked 12 hours after the last dose has been taken. So sometimes in the hospital setting, you're responsible for putting these medication orders in. The doctor will order it as like an order subset that we want to monitor these levels, but then you're the person giving the medication. So once you give that patient your medication, you're going to say, hey, I got to put in an order to monitor these levels. And then you want to put it out so that it occurs 12 hours after the time they took their last dose. Lithium controls episodes of acute mania. It helps to prevent the return of mania or depression, and it has been known to decrease the incidence of suicide. It would be contraindicated in patients who are pregnancy because it can be very harmful to the fetus. It does cross into the breast milk, so we don't want to give it to our breastfeeding moms. It's hard on the liver. And the renal, so you're going to want to probably, the doctor would really have to decide the benefits versus the risks with patients that have hepatic and kidney disease. You're going to use cautiously with patients that have cardiac disease, hypovolemia, and schizophrenia. And the thing that makes it hard is that a lot of these mental illnesses, they can all occur together. So depression, anxiety, if a person has anxiety for a certain number of years, then it can cause depression because the anxiety and the things that come with anxiety can be so draining. So sometimes you're trying to treat a multitude of things. So it kind of makes it hard finding the right medication. So the mechanism of action for our mood stabilizing drugs, they normalize the reuptake of the neurotransmitters serotonin, norepinephrine, acetylcholine, and dopamine. They increase levels of GABA. This would be your valproic acid and then your topiramate. There is something called a kindling process It's like a snowball-like effect that is seen when there's minor seizure activity. And then what happens is maybe a patient just has a very small seizure, or they show just signs of the start of a seizure, but it doesn't turn into a full-blown seizure. Well, each time they take the medicine, it causes more and more of a reaction, and then the activity just builds up, and then you start having more severe and more frequent seizures. So it's called a kindling process. We see this with the carbamazine and the valproic acid. And then lithium is considered a first-line agent in the treatment of bipolar disorder. It is the gold standard. So if your patient has lithium toxicity, this is what you're going to see. You should know this. They will have a level greater than 1.4 milliequivalents. They're going to be shaky, thirsty, frequent urination because they're drinking so much, diarrhea, vomiting, drowsiness, muscle weakness, coordination problems, giddiness. So, kind of like acting silly and laughing a lot. Blurred vision, tinnitus, ringing in the ears, seizure, slurred speech, decreased level of consciousness, and possibly death. Also, just something to think about if your patient were to take, say they took lithium in the morning and at night, and you know that you were monitoring their lithium levels, you would not give that evening dose until the drug results came back for that lithium. You would want to look at that level and make sure that it was not a toxic level before you gave the next dose of medication. That's something that you'll see based upon how often they take it and how often they're monitoring it in the hospital. Carbamazepine will cause a rash, orthostatic hypotension, aplastic anemia. So aplastic anemia is when the bone marrow doesn't make enough red or white blood cells. And then agranulocytosis is dangerously low levels of white blood cell count. So you would want to monitor for infection if your patient was on carbamazepine. Valproic acid, weight gain, alopecia, which is where you lose your hair, hand tremors, can cause liver failure, and it can have those teratogenic effects, so on the fetus, so a pregnant mom may not want to take this. And then topiramate, which is also Topamax. It can cause dizziness, sedation, and weight loss. So you can see why some people don't stick with these medications, because they have a lot of bad side effects or unpleasant. So very, very important, monitor your plasma lithium levels. Lithium levels should be monitored every 2 to 3 days when they're first determining that therapeutic dose. Then it should be monitored weekly. Once stable, then the level can be checked once a month or less frequently once that level is completely stable. So you're going to check levels 8 to 12 hours after the last dose. Daily dosages do generally range from 900 to 3,600 milligrams. Serum lithium levels should be about 1 milliequivalent. Levels less than 0.5 milliequivalent are rarely going to be therapeutic. Remember we said we start out at the lowest and then we work our way up. Well, research has shown that patients at that dose rarely receive any benefit. Levels of more than 1.5 are considered toxic. I know that other slide behind you said 1.4. I would never give you a question that said 1.4 and 1.5. It would be noticeable. And every hospital you work in or clinical setting, they're all going to have their own parameters anyway, but in that general area. Teaching your patients to take lithium with food will help with the GI distress. Older adults are at an increased risk for toxicity for the obvious reasons. Kidney issues, GI issues, liver function. caring for a client with toxicity. So if you have a patient whose level is toxic, greater than 3 milliequivalents, these are patients that might require hemodialysis because they're so toxic. You want to do education and advise the patient to take the lithium as prescribed. It must be administered in 2 to 3 doses throughout the day because it has a very short half-life. So you can't just give it in the morning and expect it to last all day because it won't. So typically they need several doses throughout the day. And then encourage the patient to adhere to laboratory appointments that are going to be needed to monitor lithium effectiveness and those adverse side effects. So anti-anxiety drugs. Anxiolytics. So we have benzodiazepines and buspirone. So buspirone is not a benzodiazepine, but we prescribe it for anxiety, so that's why it's included in this slide. The benzodiazepines are the most effective medications when treating sorry. Somebody's asking if they can get back in, but now they're not in here. I don't see them. All right, they'll come back. Benzodiazepines are the most effective. They enhance the inhibitory effects of GABA in the central nervous system. They bind to specific sites on the GABA receptor. Relief from anxiety occurs rapidly. Not obviously within 5 minutes, but if it's a PO pill, 45 minutes to an hour. So you don't, with all these other medications, we said that sometimes you're going to see that long 2 to 3 week period. That's not the case with these medications. It's going to be instant within a short amount of time. And then the buspirone is not the benzodiazepine, but it is prescribed for anxiety. It's a partial agonist activity at the serotonin receptors, and it decreases serotonin turnover, so you have more serotonin. We use these medications to treat anxiety, anxiety disorders, insomnia, obsessive compulsive disorders, depression, post-traumatic stress disorder, alcohol withdrawal, seizure disorders, muscle spasms, sometimes with the induction of anesthesia. It just kind of helps sedate them a little bit before they actually completely go under. And then as an amnesic prior to surgeries or procedures. Contraindications and precautions. We usually use these on a short, if they're being managed correctly, they should only be prescribed on a short term because of the risk of dependence. The likelihood of people getting addicted to these is very, very high. We would use cautiously in patients who are pregnant or breastfeeding, cautiously with clients who have sleep apnea or respiratory depression because it can affect, it can decrease their respiratory system, and glaucoma. It can affect the muscles in the eye and cause the open angle glaucoma. And then clients who have liver damage or a history of substance abuse disorder, you would not want to prescribe these medications. All right, so this is going to be your Xanax, your Librium, your Klonopin, your Valium, your Ativan, and your Serax. And then Buspar, obviously, is the non-benzodiazepine. So benzodiazepines, you have that physical, psychological dependence. A fear of not being able to manage anxiety causes them to overuse the medication. Withdrawal can be fatal. Seizures, so something that you will see if patients have, they're abusing drugs, and they need to come into a rehab center for withdrawal, into a detox center. Not any detox center will take these patients if they're using Xanax. So a lot of people will use heroin in Xanax. They'll use cocaine in Xanax. It's very, very easy to use Xanax and abuse it. So we see a lot of people that do that. And you can die if you are withdrawing from Xanax. So they have to be in a monitored facility for a certain amount of time. They have to receive certain medications because of the risks of death and seizure. So it can be fatal. It does have an effect on the CNS system. It causes depression. So it's going to cause sedation, lightheadedness, ataxia, decreased cognitive function. You want to advise patients to avoid hazardous activities. So driving, operating heavy equipment, machinery. Advise clients to avoid concurrent use of alcohol and other CNS depressants. It can also cause anterograde amnesia, which is the decreased ability to be able to retain new information. Patients that take it complain sometimes that they feel like they have a hangover after they take it, and then patients will develop a tolerance. So over time, the longer they take it, they're going to require higher doses. So that's why they should only be on it for a very short period of time. So the thought behind that is that first and foremost, they should be with a mental health provider because they know which medications to prescribe, and they know they're not just going through a variety of different medicines to try. They know that they can only prescribe these for a short amount of time, and then you ultimately have to get down to what the reason is that's causing your anxiety. So maybe you're just in nursing school. So you're going to take Xanax for 8 more months, and then you're going to be off of it because it's going to resolve. Or maybe it is, who knows what it is? Maybe you are in an abusive relationship at home and you have anxiety. Whatever the issue is, you can't keep treating it with the benzodiazepines. We use this for a short amount of time just to give you the energy and, your wits back about yourself to be able to make decisions, participate in therapy, get to the bottom of these issues so you don't need this medication anymore. But sometimes when it's prescribed by primary care physicians, it doesn't happen. And that's when you see these dependence issues. So toxicity, drowsiness, lethargy, confusion, respiratory depression, severe hypotension, cardiac arrest. These are all signs of an overdose. Advise the client and the family to watch for manifestations of an overdose and ensure availability of resuscitation equipment, so Narcan. Buspirone or Buspar is going to cause dizziness, sedation, nausea, headache. The elderly struggle more than any other population of people with the CNS effects. So these will be used very, very cautiously. It increases their risk of falls. It makes their confusion worse. It causes them to be uncoordinated, causing them to fall. So this is something you will see in the clinical setting when you call your doctor at 2 o'clock in the morning and say, Mrs. Jones won't stop jumping out of bed. She pulled out her IV, her NG tube. What can we give her? The doctor's probably going to hesitate a little and have to get back to you because they're very, very careful about what they give these patients because it can cause these issues to become worse instead of better. And then Buspar obviously does not have any physical dependence, which is good. So client teaching, make sure that they understand that this medication is prescribed to relieve the symptoms of anxiety. It does not treat the underlying issues causing the anxiety. That is so, so important to teach your patients. They should avoid alcohol. 1 drink with taking a benzodiazepine is the equivalent of 3. That's huge. So they cannot take this medication and drink alcohol. Advise the client to take the medication as prescribed and to avoid abrupt discontinuation to prevent those withdrawal symptoms, which is going to be that anxiety, insomnia, sweating, tremors, lightheadedness, delirium, and seizures. When discontinuing benzodiazepines that have been taken regularly for long periods and in high doses, you have to taper the dose over several weeks using a prescribed dosing schedule from the physician. So if you normally take 25 milligrams, you'll cut that pill in half and take that for 2 weeks. And then you'll cut that pill in half and take that for 2 weeks. So you do a gradual taper. You don't just stop taking it. Administer the medication with meals or snacks if you have GI upset. Instruct the client about the potential for dependency during and after treatment. And then advise clients to keep benzodiazepines in a secure place due to abuse potential. So stimulants, these are your amphetamines. We use these to treat ADHD in children and adolescents, residual attention deficit disorders in adults, and then narcolepsy. Narcolepsy is where you just have this uncontrollable urge to just fall asleep, and you do. You can't even control it. You just fall asleep. It can happen while you're driving. If you have narcolepsy, they take your license, you can't drive. It can happen anywhere at any time. So contraindications, so you would not want to give these to patients who have a history of substance abuse disorder, any cardiovascular disorders, because it's a stimulant. You can have heart palpitations, severe anxiety or psychosis. And this is a pregnancy risk. It's a category C drug, so you wouldn't want to prescribe these for patients who are pregnant. So stimulants work by causing the release of norepinephrine, dopamine, serotonin, all three of those into the central nervous system from the presynaptic nerve terminals, as opposed to having a direct agonist effect on the postsynaptic receptor. So it does work a little bit different than our other medications do. They block the reuptake of those three neurotransmitters, essentially. Side effects that we see, big side effects, anorexia and weight loss. It can cause nausea, irritability, insomnia, restlessness. You want to teach the client to observe for the effects, and if they occur, instruct the client to notify the provider. Again, this is a medication that you're only getting 30 days at a time. You cannot just call in and say, hey, my Adderall's gone, can I get another prescription? Well, you shouldn't be able to. I'm sure there are some physicians that do it. They should make you show up every 30 days, do a visit with them, make sure you still need it, and then get another prescription. You want to avoid caffeine, sugar, and chocolate because it can make your side effects worse. And then growth and weight suppression. So this is a huge issue, especially with children. A lot of children take these medications. The physicians are constantly monitoring the client's height and weight, and we're comparing it to their baseline. So before they started this medication. Some children may require a drug holiday. So that means if they don't take it on the weekends, they don't take it on holidays, and they don't take it during the summer. Helps restore that normal growth pattern and their eating pattern. So it causes anorexia. They don't have any type of appetite at all. Some adults that take this medication, they will say this is a great side of the medication because they're losing weight. They like that. Cardiovascular effects, it can cause certain dysrhythmias, chest pain, high blood pressure. So you want to make sure you're monitoring their vital signs and do like a baseline ECG before they start, and then probably periodically per the provider throughout treatment. You want to watch for the development of psychotic manifestations, so hallucinations and paranoia. And then you want to watch for a withdrawal reaction. So advise the client to avoid abrupt cessation of the medication, as it could lead to depression and severe fatigue. More client teaching, take the dose after meals or the last dose of the day. Should be given by 4 p.m. It's a stimulant. We don't want to keep the patient up all night, right? So you don't want to take this medication at 9 o'clock at night. Advise clients to swallow sustained release tablets whole and to not chew or crush them. Avoid alcohol, caffeine, sugar, and chocolate. And then make sure proper storage is maintained. You keep out of the reach of children. A 10-day supply can be fatal. Okay, disulfiram. So this is what they call, it's also called antabuse. This is a sensitizing agent that causes an adverse reaction in the patient's body when it's mixed with alcohol. So we give this to patients as a deterrent to drinking. So these would be for patients who are suffering with alcohol abuse. It's an aversion therapy for alcoholism in patients who are ready to quit drinking. You're going to have that adverse reaction 5 to 10 minutes after a person taking the antabuse ingest alcohol. symptoms start to appear. So you're going to have facial and body flushing because you're going to have a vasodilation throughout the whole body. You're going to have throbbing headache, sweating, dry mouth, nausea, vomiting, dizziness, and weakness. So all of those are meant to serve as a deterrent to keep them from drinking because they don't want to feel like that. Side effects: fatigue, drowsiness, halitosis, tremor, and impotence. So you will see drug interactions with the metabolism of other medications when you take Antabuse. If you're taking Dilantin, isoniazid, warfarin, certain barbiturates, and then those long-acting benzodiazepines. So client teaching, we're going to avoid alcohol, and we want to include common products that can contain alcohol, which most people don't even know. So shaving cream, aftershave lotion, deodorant, and then those over-the-counter medications like cough preparations or cough syrups, they have alcohol in them. So cultural considerations. Some cultures will have specific reactions to specific medications. So with our African-American patients, they, more so than white Americans, have a greater risk of side effects with tricyclic antidepressants, those TCAs. They have a more rapid response to antipsychotics. Asians metabolize antipsychotics and TCAs more slowly than white people, and therefore they require lower doses to be able to achieve the same therapeutic effects. Lower doses of antidepressants for Hispanics than whites to achieve desired effects, and then lower doses of lithium for Asian and African Americans compared to whites in order to produce the same desired effects. We also have to be aware of the increased frequency of herbal medications. Remember we talked that there's a lot of, some cultures prevent them from coming in for mental, to seeking help for mental illnesses. Some people are embarrassed to seek help. There's a lot of stigmatism around these. So they will try over-the-counter things first. And you know that over-the-counter medicine can affect a lot of things. So we really need to make sure we're asking our patients about that. So a lot of people will take St. John's wort that has been known to treat depression. Some people take kava that is used for anxiety. Some people use valerian or valerian root. It has been known to help enhance sleep, relieve stress and anxiety. And then ginkgo biloba is used to improve memory. So herbal medications are often chemically complex and are not standardized for regulated use in treating illnesses. And they also are at an increased risk of interactions. So we don't, as providers, ever recommend them taking these. So what are some common barriers to maintaining medication management? Well, long-term chronic illnesses require ongoing treatment, not just taking medication and going once every 30 days. It requires seeing a physical therapist on a weekly basis, a bi-weekly basis. That's hard for people to commit. Sometimes people don't want to talk about the things that cause them or the things that bother them or cause their issues because it makes them deal with things that they don't want to talk about. That affects compliance. We see, like I said earlier, patients start taking the medication, they start feeling better, they assume their symptoms are gone, they stop taking the medication, those symptoms return. Often when clients stop taking medications or they take it improperly, not because they don't intend to, it's just a result of faulty thinking or reasoning, which is in reality part of their illness. So really doing that education, talking to them about side effects, what will they expect, how long before they're going to feel better, when should they call the doctor, and then major side effects and interactions of the medications. Some of those medication side effects could be very debilitating, and they might feel that it's not even worth it. I'd rather just be anxious than have diarrhea and feel, exhausted all the time. And then the stereotyping and the discrimination against mental illness. We know how that can be. All right, so self-awareness issues, there's always something for the nurse to be aware of about herself and how she feels about things. So we have to understand that chronic illnesses have remissions and exacerbations just like anything else, just like the cancer patients, just like patients who don't manage their diabetes, just like patients who don't manage their hypertension. We don't think of them in any certain way. We don't pass judgment on them. We can't do it with mental illness either. It is a chronic illness, just like all of the physical illnesses that we will be treating. We have to remain open to new ideas that can lead to future breakthroughs. We want to be open to new therapies that patients want to talk about, pass that information along to the physicians, and then understand that medication non-compliance is also part of the illness and not a willful misbehavior. There's always another issue. It's not because they just woke up and said, I'm sick of taking this medication, I don't want to do it anymore. There's always a reason behind it. All right, so now we are going to answer some questions. All right, so when the client asks the nurse, how long will it take before the selective serotonin reuptake inhibitor, that SSRI, antidepressant medication will be effective, which reply is most accurate and therapeutic? This is a good medication. It will be effective within 20 minutes of the first dose. B, you will have gradual improvement in symptoms over the next few weeks, but the changes may be so subtle that you may not notice them for a while. It's important for you to keep taking the medication. C, it will probably take months for the medication to work. In the meantime, you should work on improving your attitude. Or D, if you believe it worked, then it will. You have to have faith.
B.
D.
You gradually improve.
Yes, very good. So that is what you want to teach your patient. It's not going to be initial. It's going to take several weeks. All right, a client is experiencing hallucinations and delusions. The nurse would expect the physician to order which class of drug: an antipsychotic, a mood stabilizer, an anti-anxiety agent, or a stimulant.
Antipsychotic. B.
C.
B.
B, an antipsychotic. Yes. Hallucinations, delusions, schizophrenia. That is an antipsychotic drug. Very good. All right. Which statement about the neurobiologic causes of mental illness is most accurate? Genetics and hereditary can explain all causes of mental illness. Viral infection has been proven to be the cause of schizophrenia. There is no evidence that the immune system is related to mental illness, or several mental disorders may be linked to genetic and non-genetic factors.
The last one.
D.
Yes, several mental disorders may be linked to genetic and non-genetic factors. Very good. Oops. Which medication classification is used to treat psychosis and mania?
Psychotic. B.
Antipsychotic.
A.
Very good. Which neurological function is governed by the action of serotonin?
Mood.
Mood.
C.
Heart rate.
Yep. Mood. Very good.
Mood.
A group of nursing students are reviewing information related to drug therapy for mood disorders. The students demonstrate understanding of the information when they identify which agent as the gold standard for treating bipolar disorder. Lithium. Yep.
Lithium. B.
Good. Lithium. A client has been diagnosed with Parkinson's disease. Which neurotransmitter is decreased in those with Parkinson's disease?
Dopamine.
Dopamine.
A.
Very good, A. All right, a client is brought to the emergency room department with reports of slurred speech, spasms, jerky movements. The significant other shows the nurse a pill bottle and states that the client has been taking antipsychotic medications for a while. The nurse notices that an improper dose is ordered on the prescription bottle. How would the nurse explain what system is causing the movements? Dysfunction of the corticospinal motor tract may include masses such as strokes, subdural hemorrhage, abscesses, and tumors. Dysfunction of the pyramidal motor tract can manifest plantar extension and hyperreflexia. Dysfunction of the primary motor cortex can manifest in paralysis on the opposite side of the body, or dysfunction of the extrapyramidal motor tract can manifest serious neurologic symptoms such as dystonia, pseudo-Parkinsonism, and akathisia.
The last
D.
one.
Yes, very good. Those are your
D.
EPSs. Yep,
Okay.
very good. Those are your EPSs. All right, you guys have any questions? God, that didn't take long at all. We got through that quickly.
I have a question really fast about the movie assignment. What I keep trying to find the date and like when that's due. When exactly is that due? The movie presentation thing, or the assignment in general?
It's like July the 28th or something like that.
Hold on, I'm looking at the calendar. July 8th. July 8th, your movie assignment is due. Yep, it's on your calendar. Yep, July 8th.
I have a question. The group assignment coming up, my group has vision health. I don't know if anybody contacted you, but we weren't sure if you wanted a broad vision health or do we choose a specific type of vision issue?
No, I would just talk about the vision health in general.
Okay.
Yep. So I want to talk about this group project that's due. So I've been hearing from a couple different people that other group members are not reaching out to each other. This assignment is due after your exam. You guys need to be reaching out to each other. You guys are going to do peer reviews on each other after you complete this assignment. And if I get paperwork back stating that certain people didn't participate, then you're not going to get the grade that everybody else gets. So I know you guys are busy. I know you're studying. Homeostasis is crazy, but each are only doing a small part. It's a group project. So you guys need to work together, contact each other, and make sure that you are getting this assignment done, please. If there's someone on here now that hasn't responded to someone else and you need their email or you don't have it, I would ask them now while we're on here and you have access to them. I also uploaded clinical paperwork. So for the group that already went, your clinical paper is online. There are assignments in there that you need to complete. The group going this week, you also have to print that out as well. You want to print it out before you go to clinical. There is a assessment sheet like you filled out last semester for your spices assignment that has where you find all the abnormal findings. You're going to be doing physical assessments on your patients each week, and you're going to be filling that out each week and writing a nursing diagnosis every week that you're there. So you need to print enough of them out. Most of you are going to be going right now, it looks like at least 5 or 6 times. So make sure you have enough paperwork because you're expected to have that. You can't print it at the facilities. We can't use their copy paper or their printer, whatever. And it'll be an unsatisfactory for the day if you do not come with the appropriate paperwork. The patient, so during week 2, so the group that went last week, this is going to be this week for you. The patient that you have this week is going to be the patient that you are doing your concept map on. I will pass that information on to your clinical instructor. Make sure you let her know so that she chooses a good patient for you. We don't want a patient that doesn't hardly have anything wrong with them. You need to know how to do this nursing process assignment and that concept map. There are also, there's a homeostasis, a nutrition, and an oxygenation assignment that you will do. I have them slotted on your paperwork, like where you should do them. Ultimately, I don't care where you do them. You know, if there's 5 of you in clinical, 2 of you might not have a patient that has homeostasis if you're doing homeostasis this week. So however she wants to do that, I'm fine with, just as long as you guys talk about it and you do it. It can even be something that you do in post-conference. It's not anything you do for a grade. It's just how you look at the patient that has oxygenation issues, homeostasis issues, and who has nutritional deficits. So that's up to the person. I think it was by week 4 that concept map is due. It is going to be due to your clinical instructor, not me. So she will be grading it. You will turn it into her, print it off, unless she tells you otherwise. Bring it with you to clinical and be ready to hand it in at the beginning of the day. It looks like the people that are going to Sinai don't need COVID tests, so that's a plus. Yeah, I think that's it for clinical. Do you have any questions about clinical? I know that happened pretty
Are you
quick.
talking about the people who are going to Levendale?
Oh, is that where you're going? You're going to Levendale now?
No, I'm at Sinai. I'm already at Sinai. We
Oh,
already started. Yeah.
Okay. Yeah, I mean, if anybody has any questions in general or the new group that's going this week, I know it happened pretty quickly. That's how it's going to happen. So you should just assume every week that you're going to clinical until you hear otherwise. And if you don't, then that's great. It's like a bonus day. Okay.
Okay, hold on.
I know some people were concerned, like, do we have to have COVID testing for this semester? I mean, it's clinical rotation.
The one that starts this Sunday or when your turn in general
I'm not
starts?
sure which one. It was just a question that came up in our group chat.
So it's gonna, the facility's gonna dictate that, not us. We just have to follow what the facility says. So until we, the last 2 groups, it looks like the ones that are going don't need to have them right now. So depending on what facility you're in, I don't know about GBMC and I work there. I don't even know what they are requiring. I don't think you have to have weekly testing. I think they just see if you need symptoms, if you have symptoms or not. But that group is not going to start until June. I think it's June 6th. That group has not been, Cheryl hasn't, Dr. McNamara hasn't formed those groups yet though. She's working on it.
How do I know if I've been assigned yet?
Okay, so I have a question. So how does